Unfortunately, echocardiography is a fairly crude method to quantify left ventricular hypertrophy. There are much better methods, for example, magnetic resonance imaging or computed tomography. But you will see that with the help of echocardiography, it's reasonable to quantify LVH and to make the diagnosis in most patients. But in this chapter, I also want to show you other factors which are associated with LVH, and I also want to show you other causes of LVH. So let's take a look. I want to start out with the probably most applied method of measuring the thickness of the septum, the M mode of the left ventricle. So how do we quantify the thickness of the interventricular septum using M mode? Before we do the measurement, we first have to look at the peristernal long axis view to see if we can actually perform the M mode measurement. So the problem that we immediately see is that the image quality here is not the best of all image qualities, but that is something we see quite often in patients who are hypertensives. The second problem, which is even more of a problem, is that we have an angulation between the septum and the aorta. This means that we do not have the optimal transducer position, and we would have to move the transducer up one intercostal area, space. But if I do so, I see that I do not get any image quality at all. So I have to stick with what I have and try to see what I can get out of this. Now, I would in this case turn the transducer into a short axis view, and then from this view I would try to go up as cranial as possible within the intercostal space, and you see the ventricle is quite round, so it's not as bad as it seems, and I think we can at least try to perform M mode in this patient. And to further optimize the image, what I would now do is I would have him exhale. Können Sie mal ein bisschen ausatmen? You see if he exhales, the image quality improves slightly, and then put the M mode right in the middle of the ventricle and freeze the image. Okay, so this is the M mode we get, not the best of all M mode qualities, but we'll measure nevertheless. So I would now start the measurement program. I would start here at the end diastole with the right ventricular vicinity of the septum and measure the thickness of the septum. Now the problems we have is we do not really know if we are not getting some structures of the right ventricle into our view, for example the moderator band, but we'll just take it as it is for the moment. Then we have the end diastolic diameter and we have the measurement of the posterior wall. For hypertrophy, this is all you would need. We're not doing function. We only need the thickness of the septum and the posterior wall. When you perform the M mode, you have to be aware that there are a number of pitfalls. A major pitfall is that very often you will get right ventricular structures such as the moderator band into the view or the ray of the M mode, and thereby you would overestimate the thickness of the septum. The second problem is that you might transverse the septum not perpendicular, but oblique, and therefore also overestimate the thickness of the septum. And the third problem is that, especially in the posterolateral region, you could have subvalvular structures which appear to be part of the wall, and thereby you would overestimate the thickness of the posterolateral wall. I personally believe that the M mode is probably not the best way to really quantify left ventricular hypertrophy. It should only be performed in patients where you have a good image quality. I think that you should prefer 2D measurements or other measurements such as mass calculations if you really want to get reliable measurements. So this is how you would perform a measurement of the interventricular septum with 2D. In principle, you can use both the apical and the peristernal approach. I will first show you the peristernal approach, where I would recommend the short axis view. You would try to again optimize the image and freeze the image at end diastole, and then simply perform a conventional 2D measurement of the septum. I personally prefer the apical view to measure the interventricular septum. To get good measurements, it's advisable to try to again tilt the transducer in such a way that we have a better angulation of the ultrasound beam with the septum. In other words, that we're more perpendicular. So I'm more lateral now with the transducer position. Then I freeze the image. Then I perform a measurement of the septum, which I would perform in a region of the septum which is located where you would also measure the M-mode. So it's between the mitral valve and the papillary muscle. However, I would avoid to measure the maximal thickness if the patient has prominent mid-ventricular septal hypertrophy. So I would then measure somewhere below or above this region. Here are two examples where you can measure the septum in a short axis view and a 4-chamber view. Remember, we measure at end diastole. We should measure the mid-septum, and beware of problems such as the still framing problem where you do not use an end diastolic frame, and thereby you could overestimate the thickness of the septum. RV structures could come into your field of measurement, and this would also lead to overestimation, very similar to what happens in M-mode. And the shape of the septum can cause problems because the shape of the septum can be such that the thickness is not the same in all regions, proximal, mid, and distal. Here are the normal values for the thickness of the septum. For males, the upper limit is 10, for females 9. But be careful, if you have a septal thickness of 11, this does not necessarily mean that the patient really has hypertrophy. It could also be only a measurement error. The upper limit would be 17 for males and 16 for females. Above this value, you could consider hypertrophy to be severe. This is an example of a problem or of a patient who has a so-called sigmoid septum. What is a sigmoid septum? It's a septum which has an S shape and where you have portions of the septum which protrude into the left ventricular outflow tract. This is a phenomenon you see very often in patients who also have left ventricular hypertrophy and hypertension. Usually the thickness of a sigmoid septum is less than 3 centimeters in length, so it's only a regional problem. And as I already mentioned, it can be associated or is often associated with hypertension and LVH. What is the clinical importance of this finding? Well, it can become obstructive. It can cause a so-called SAM phenomena if patients also have a hypovolemic left ventricle or if they're hyperdynamic. So this can arise and can cause a problem, but it is not the same thing as if you have a hypertrophic cardiomyopathy. Now I'd like to show you how to quantify LV mass. A number of different methods have been proposed, among them the so-called M-mode method, which uses the formula by Desvarieux. This formula is shown down here. This method uses the thickness of the septum, the posterior wall, and the diameter of the left ventricle at end diastole. This formula, however, is not very exact since it makes a number of geometric assumptions which don't hold true in all patients. In addition, there are measurement errors involved, so I would not prefer to use this method. I would prefer to use the so-called 2D method, which you see here. The 2D method uses the thickness of the septum in a short axis view and also the length. Therefore, it is called the so-called area length method. You can see the formula here. Now I'd like to show you how to perform this measurement practically. To quantify left ventricular hypertrophy with the help of LV mass, you first need the length of the left ventricle. To do that, you would obtain a 4-chamber view, freeze the image at end diastole, and measure the length from the tip of the left ventricle to the plane of the mitral annulus. Next, you would perform a short axis view of the left ventricle in the region between the papillary muscle and the mitral valve. You would freeze the image at end diastole again, and then you would contour the left ventricle first on the outside, on the epicardial surface, not into the pericardium, and then on the inside, where you would just transverse the papillary muscle. So I'm just cutting through the papillary muscle here. And you would get a measurement of 285 grams, which denotes left ventricular hypertrophy. You could then perform the same measurement also in systole with the end systolic length of the left ventricle. These two measurements, however, should at least moderately, should agree. These are the normal values for LV mass. But remember, these values are very strongly dependent on body surface area, and there is a non-linear correlation. These values also correlate with height. For males, the upper limit would be somewhere in the range of 102 grams, for males 88 grams. Patients who have severe hypertrophy are above 131 grams, but you will see patients who have values somewhere even above 300 grams in severe forms such as hypertrophic cardiomyopathy. I now want to turn away from left ventricular hypertrophy and look at other features of patients with hypertensive heart disease. We've already mentioned that we have left atrial enlargement in these patients. But what is interesting, we also see RV hypertrophy. So interestingly, there also seems to be another reason for the development of hypertrophy aside from the pressure overload of the left ventricle, which also affects the right ventricle. Diastolic dysfunction is a very frequent finding in hypertensive patients, and dilated aorta as well. Now this is such an example of a patient with massive left ventricular hypertrophy and left atrial enlargement. The occurrence of left atrial enlargement depends on the method of measurement, and it also depends on the degree and severity of left ventricular hypertrophy, in other words, on the value of mass, and age, but also obesity play a role. Very commonly, we see an association of left atrial enlargement and atrial fibrillation. A frequent finding in hypertensive heart disease is diastolic dysfunction. Probably a quarter of all hypertensive patients have diastolic dysfunction. It has been estimated that 50% of heart failure patients have diastolic dysfunction, which has also been called HFnEF, meaning heart failure with normal ejection fraction. Usually, diastolic dysfunction is mild. We see so-called disturbed relaxation patterns, or moderate, so-called pseudonormal filling. Important, as we will see in the chapter on diastolic dysfunction, this will help us to estimate the filling pressure, which is very important also in hypertensive patients. I already mentioned that right ventricular hypertrophy is also frequently found in patients who have left ventricular hypertrophy, even in the absence of pulmonary hypertension. So other factors that contribute to hypertrophy other than LV afterload also play a role. This difference, or this hypertrophy, is usually subtle and mild, and it's very difficult to really detect hypertrophy of the right ventricle with echo. More importantly, you will very frequently find a dilated aorta in patients with hypertensive heart disease. You can see that the frequency is even larger in males than in females, with a cutoff value of above 40 for males and 38 for females. There's a correlation of the dilatation of the aorta to the severity of hypertension, to the age, and also to diabetes. This is such an example. You can nicely see both hypertrophy being present and also a dilated aorta, which is clearly visible in the parasternal long axis view. Initially, you have reduction in longitudinal contraction, and then finally also in radial contraction. And what you see here is such an example where we already have a reduction in ejection fraction. Usually the patients have symptoms of dyspnea in this stage. Echo is extremely valuable in patients with hypertensive heart disease. Very often you will be able to make the diagnosis simply because you find hypertrophy. Remember, many patients don't know what their true blood pressure values are. It is possible to assess the risk and the severity of hypertension by quantifying the degree of left ventricular hypertrophy, by looking at the size of the left atrium, and it is possible to also find associated problems. For example, if the patient is at increased risk of atrial fibrillation. In many patients, you can also use echocardiography to guide therapy. Does he need more diuretics? Does the patient benefit maybe from a beta blockade, or should the patient be aggressively treated versus mildly treated? So what if you have LVH in the absence of hypertension? Well, there could be a number of reasons. First, maybe you just performed a false measurement and you overestimated the thickness of the septum. Second, the patient is an athlete.
Third, the patient does have hypertension but just doesn't know. Or fourth, there is another cause of LVH. Now let's take a look at the athlete heart first. Rarely would you develop a septum which is more than 13 millimeters. You have to perform intensive, prolonged endurance training of more than 1 hour a day to develop hypertrophy. To differentiate the pathological from the physiological forms of hypertrophy, you can use strain and strain rate, which are newer methodologies, and you can also use the relative wall thickness, which should be below 0.45 in athletes. This is an interesting study which was performed in professional tennis players. It shows you first of all the occurrence of LVH and also the different forms of LVH. The cutoff values are shown here. You can see that only 17% had a normal myocardial thickening in professional tennis player, and most of the forms were so-called eccentric LVH forms, opposed to 22% who had concentric and 7% who had concentric remodeling. I just want to briefly mention that athletes seem to have a different contractile pattern opposed to hypertensives. Most likely, athletes are able to recruit additional longitudinal contractile function during exercise. Here is a list of other causes of LVH aside from hypertensive heart disease: aortic stenosis and coarctation, hypertrophic cardiomyopathy, infiltrative heart disease such as sarcoid heart disease and morbus Fabry, and eccentric forms of left ventricular hypertrophy often seen in aortic regurgitation and mitral regurgitation. Sometimes it's very difficult to distinguish hypertensive heart disease from hypertrophic cardiomyopathy. What you will find very often in hypertrophic cardiomyopathy is a more disproportionate form of LVH. You can see that the septum is extremely thick in this patient, opposed to a more concentric form that you would find in a hypertensive patient. Other features of hypertrophic cardiomyopathy are the typical SAM phenomena, but beware, this can also be found in patients with hypertensive heart disease. Just a few words about strain. Well, there is evidence that patients with hypertensive heart disease have a different pattern with respect to strain than patients with hypertrophic cardiomyopathy. But it's probably too early yet to really describe the exact pattern and the exact difference between the two. So this is something that will maybe be important in the future, but presently we cannot use it on a routine basis to really differentiate them. This table just shows you the different features of hypertrophic cardiomyopathy and hypertensive heart disease and how we can differentiate the two. This table can also be found in your fact sheets. So now that we've heard all this information, let's see an actual patient with hypertensive heart disease and let's see what we can find with echo. Here's our patient. And I want to start with an apical view, with a 4-chamber view, just to give you an impression of hypertrophy in this patient. So it's quite clear that the patient has hypertrophy. And the question is, does the patient have hypertensive heart disease or does the patient have hypertrophic cardiomyopathy? So when we look at the different segments, and we can see that most, or actually all segments have the same wall thickness, so this speaks in favor of a hypertensive heart disease. And if we look at the apical segments, we see that the apical segments are not more hypertrophied than the rest, so this does not look like an apical hypertrophy, but more like a concentric hypertrophy. The other thing we see is that the patient does not have obstruction of the LVOT, there's no SAM phenomena, and also with color we see no turbulent flow. And if you also take a look at the short axis view, you can see that hypertrophy is concentric. So all segments have approximately the same wall thickness. Certainly hypertrophy can also be asymmetric in patients with hypertensive heart disease, but this altogether looks very much like hypertensive heart disease. So if you look at the clinic as the patient as well, and you know that the patient had hypertension for many, many years, that diagnosis is quite clear. Okay, so are you ready for the next case? This is another patient with left ventricular hypertrophy. So let's take a look first at his parasternal long axis.
Again, we have left ventricular hypertrophy. Now let's turn to the short axis. And there's no question, the septum is very thick in this patient. Let's just measure it somewhere in this region. Now this is 33 millimeters, which is severely hypertrophic. But opposed to the patient you saw previously, hypertrophy is not symmetric, but different regions of the myocardium show different wall thickness. For example, if you measure the wall here in this region, it's almost normal, it's 13 to 14 millimeters. Or if you measure the posterolateral wall, it is much less, 15. And even within the septum you have differences with respect to the thickness of the wall. So this is an asymmetric pattern of left ventricular hypertrophy, which is very indicative of hypertrophic non-obstructive cardiomyopathy opposed to hypertension, where you can have some degree of differences with respect to the thickness of the wall, but never to that degree. In addition, the speckled appearance of the interventricular septum and the myocardium is also in favor of hypertrophic cardiomyopathy.
Okay, so now we're done with the chapter. I would now recommend that you view the summary, then go to the atlas to see a few cases, and finally proceed to the quiz to test your knowledge.